history of interventional cardiovascular medicine, the creativity of the early physicians and the courage of their patients, offers a dramatic context for current cardiovascular care. The year is 1929, and 25-year-old Werner Forsman, a young doctor in Berlin, catheterizes his own heart. Dr. Forsman proved that it was possible to safely place a catheter in a beating human heart and set the stage for expanding cardiac diagnosis beyond physical examination, X-ray, and electrocardiography. In the early 1960s, Charles Dotter realized that a catheter could be used for more than diagnosis. Dr. Dotter's technique involved dilating the artery with progressively larger catheters. He successfully treated an 82-year-old woman facing amputation of her gangrenous foot by using a sequence of progressively larger catheters to dilate her occluded iliac artery. The technique worked, with immediate restoration of blood flow to the foot, providing the desired outcome, saving the foot and launching catheter-based intervention. Another pioneer, Mason Sones, launched a new era of coronary angiography, building a foundation for direct coronary bypass surgery. René Favalero developed early techniques for bypass surgery, and other surgeons expanded arterial grafting to restore blood flow in the coronary vessels. With this foundation, a young German physician in Zurich was able to develop a procedure that would transform cardiovascular medicine. Andreas Gruentzig developed endovascular interventions with critical support and insight from surgeons and anesthesiologists. Contemporary culture was tantalized by the possibilities of endovascular interventions. The science fiction film Fantastic Voyage was released in 1966, and Isaac Asimov, author of the screenplay, gave the keynote speech at the first conference for the Association for the Advancement of Medical Instrumentation in 1967. In 1969, Neil Armstrong walked on the moon and spoke the words that resonated around the world.
It's one small step for man, one giant leap for mankind.
At the same time, physicians were building tools to better explore vessels with greater precision and control. With his passion and drive to further refine intravascular intervention, Dr. Gruentzig took Dr. Dotter's idea to an entirely new level. By placing a balloon at the end of a catheter, he had now developed an agile device that could enter the vessel through a small aperture and mechanically expand and dilate the vessel to enhance blood flow. Working diligently on animal models and building balloon catheters, Gruentzig perfected and expanded the targets for his technique. Intervention within the coronary arteries was now possible. In 1977, he performed the first coronary artery balloon angioplasty on Dolph Bachmann, a brave 38-year-old man who opted for the promise of the new procedure to treat his angina rather than the more invasive open-heart surgery. The success of this procedure encouraged further development of the technique. Dr. Gruentzig presented the results of his fourth angioplasty case, performed in Frankfurt, at the 1977 American Heart Association meeting. This dramatic result led to increasing acknowledgement of his pioneering work. Prompt primary angioplasty interrupts and sometimes aborts heart attacks, saving countless lives every day. Early hospital discharge has now become a reality. Patients who could not walk due to claudication are walking. Those with acquired and congenital heart disease are having their defects repaired without open surgical intervention. Interventional cardiovascular medicine has enabled the radiologist, surgeon, and cardiologist to enhance patient care, increase the quality of life, and decrease morbidity and mortality for an ever-expanding range of conditions in the coronary and peripheral vascular systems. To accommodate the training needs of this new technique, Dr. Gruentzig used the common surgical training practice of mentoring clinical decisions and procedural skills. He combined that with live video broadcasts, where triumphs and mistakes could be seen as they occurred. The physician could now witness many procedures prior to attempting the procedure on a patient. The demonstration courses began in a small auditorium in Zurich and expanded at Emory University in Atlanta. They provided the initial training for the first wave of interventionalists. These teaching methods grew, and as new technologies became available, interventionalists learned through new device demonstration courses in Santa Barbara and Monaco in the late 1980s and early 1990s. Interventional mega courses emerged in the form of TCT, EuroPCR, CCT, SCAI, the ACCI2 Summit, and many others. Academic training for interventional cardiologists was formally established in the late 1990s with approval of the curriculum by the Accreditation Council for Graduate Medical Education and the certifying examination of the American Board of Internal Medicine. The American College of Cardiology, the Society for Cardiovascular Angiography and Interventions, the Society for Vascular Surgery, and others have developed training materials and courses to prepare for these examinations. To date, almost 6,000 cardiologists have been board certified as competent in interventional cardiovascular medicine. Journals have been developed to report the results of the many trials and other research specific to this field. Just as Gruentzig pioneered the use of television and live demonstrations in the early days of balloon angioplasty, enhanced educational technologies such as training simulators, online courses, and outcomes-based educational assessments will provide the next steps for further enhancing the training of interventional cardiologists. Dr. Gruentzig's knowledge from animal and material science research led to the design of the initial balloon catheter. He methodically refined his clinical interpretation and technique. Finally, he carefully defined patient and lesion selection and worked to establish credible outcome metrics. The principles of engineering and material science were also vital components. The pioneers in interventional procedures worked diligently to refine the balloon catheter. For example, the material used to manufacture the balloon had to have the appropriate tensile strength, reproducible inflated shape, and dependability. This was not a trivial quest. Engineering and animal research continue to play a critical role as more sophisticated, smaller devices such as directional atherectomy, extraction atherectomy, rotary ablation, and laser balloons are developed. New therapeutic agents which can be administered through catheters are in development, such as growth factors to promote angiogenesis. Devices for longer-term placement in the body, such as new stents, replacement valves, and pacemaker leads, are also being designed. Selecting the proper materials is critical. Devices cannot create excessive scarring or vessel occlusion, or suffer from material fatigue that would diminish their structural integrity. Computer design has brought about increased sophistication and refinement, and led to the development of self-assembling devices and devices that change over time, such as self-absorbing stents. Patient selection has been a critical research component for interventional cardiovascular medicine. We have better tools than ever before to evaluate anatomy, age, sex, ethnicity, and to examine genetic markers and their role in disease and response to therapy. This data has become the backbone of evidence-based guidelines that drive clinical practice decisions. Critical to the success of this procedure were the measurable outcomes, providing clinical credibility to the rapidly growing field of interventional cardiovascular medicine. A registry sponsored by the National Heart, Lung, and Blood Institute enhanced documentation of the early angioplasty results. The commitment of Dr. Catherine Dietrich and her team at the University of Pittsburgh School of Public Health was pivotal in supporting the investigators in performing high-quality data collection over the ensuing 30 years. Subsequent state, regional, and national registries, for example, New York State Registry, Northern New England Registry, and the ACC National Cardiovascular Data Registry, have further defined the strengths and limitations of the method. The interplay between outcomes and innovation occurred early on in the development of angioplasty with the introduction of stents, drug-eluting stents, and concomitant therapies. When the elasticity of the coronary vessels was seen to be causing reocclusion, the stent was introduced. When complications arose related to bare metal stents, drug-eluting stents were introduced, along with blood thinners and platelet inhibitors. Devices and techniques are constantly being developed to improve the efficacy of procedures, decrease complications, and tackle new clinical challenges and conditions. An interesting byproduct of angioplasty has been research focused on minimizing the complications which arise from the procedure. Acute endothelial vessel wall damage produced clinical manifestations that necessitated antithrombotic research. Coronary interventions provided the laboratory for evaluating heparins, antithrombins, antiplatelet agents, and more. The healing response led to overdevelopment of tissue, which in turn leads to restenosis. Discovery of the central role of cell growth led to research on agents that inhibit restenosis, which led to development of drug-eluting stents. Much of the research in vascular biology, angiogenesis, myogenesis, and related processes has emanated from the effects of interventional cardiovascular procedures. Implantation of progenitor cells capable of regenerating myocardium holds promise for future treatment of those with severe heart failure. Pharmacological innovations such as antithrombins and thrombolytics were stimulated by interventional procedures. The spirit of innovation, research, and entrepreneurship exemplified by investigators, inventors, and industry drives development of safer, more cost-effective treatment options for the present and future. Cardiology training and practice were forever changed by the introduction of interventional cardiovascular medicine. As Dr. Gruentzig said during the early education sessions, "You are responsible as I am for the future of this procedure." Let us recognize the vision and perseverance that enabled the creation of interventional cardiovascular medicine and celebrate the profound impact that it has made in the lives of patients past, present, and future.